Lot.
Hello, Sadiq. Hello, everybody. Thanks very much for your kind invitation, your kind introduction. It's a real honor to be with you today to speak about spinal cord stimulation, my passion. My conflicts of interest, I'm consultant for these four companies. The agenda. Over the next minutes, I'm going to say some things about the current role of this therapy in interventional pain management, about how we got to these new spinal cord stimulation systems that we have, why I think we have a new era now, and what the future will bring in this area. Let's start with the first point, the current role. So I always like to show a small video. The train is the chronic pain patient. The man here is the physician. He's trying to remove all obstacles or he's trying to help all chronic pain patients. Sometimes it's possible, sometimes it's not so easy, but at least we are trying. The pain itself is something really difficult. I think you all know what Heraclitus once said or wrote, no man ever steps in the same river twice, for it's not the same river and he's not the same man. Here is a small video. It is taken in Ikaria, a small island in Greece, the waves, and 2 minutes later, we have this video here. It's the same location, but we see the waves are different. The same with the pain. Each time, pain can be different. The pain phases are also different. A provocative question, what's like to be a microchiropteron? What's like to be a bat? This was the title of an article published in 1974. I wasn't born back then. In a Philosophical Review, it's an article about consciousness, and the author wrote these experiences, for example, hunger, pain, also have in its case a specific subjective character, which is beyond our ability to conceive. This is why it's difficult. It is not easy to understand what it's like not be able to hear something if you're deaf, or not see something if you are blind. With chronic pain, sometimes we have some bigger problems. This is the German version of the pain detect questionnaire. You see the patient here should write how strong the pain is, how severe the pain is on this scale from 0 to 10. And she wrote these numbers. It took us some seconds to figure it out. It's actually her mobile phone number. There are different things we can do in order to treat chronic pain. This is something I found on Instagram. It's coming from Brazil. This could be one option, but we have also other options. We have the interventional pain therapy. This therapy can act at the level of the first neuron. Here we have dorsal root ganglion stimulation or the pulse radio frequency. We have subcutaneous leads, peripheral nerve field stimulation or peripheral nerve stimulation. We can act at the level of the second neuron, spinal cord stimulation, the topic of our talk today, and the intrathecal therapy with or without opioids or combination of different drugs. And the level of the third neuron, we have the motor cortex stimulation and the deep brain stimulation. You all know Professor Tolba mentioned that last week. There are many pain conditions that can be treated, especially for spinal cord stimulation. The indications could be a trigeminal neuropathy, not neuralgia, neuropathy, patients with Thel-Back surgery syndrome, or the new term persistent spinal pain syndrome, with back pain, leg pain, arm pain, neck pain, radiculopathies, patients with phantom and stump pain, with polyneuropathies after chemotherapy, for example, plexus lesions, angina pectoris, peripheral vascular disease, postherpetic neuralgia, and complex regional pain syndrome with or without capsalgia. I don't know if you know this guy. I don't know if this could help a little bit. He is Benjamin Franklin. He was a philosopher, an inventor, a writer, a diplomat, a scientist, but the main passion of Benjamin Franklin was writing. He wanted to become a really good writer. So what did he do? He took The Spectator, the most prestigious magazine in his time. He chose an article. He kept notes about this article in his notebook. And some weeks later, he tried, using his own notes, to rewrite the article. He did it all over again, till in the end, after some years, his own version was much better than the original version of the article. So he kept evolving. It's the same thing with our pain therapies. They are keep evolving. And we do have a paradigm shift. This is a very interesting article from Dr. Maguire and Slavin. And the authors are stating that now we have a trend or a paradigm shift away from the World Health Organization analgesic ladder toward an earlier surgical intervention. And this is important for patients, but this is important for the public health and the society. I think you all know this ladder of the World Health Organization. What we have seen is that if we start offering our neuromodulation options, such as pulse radiofrequency, peripheral nerve field stimulation, or spinal cord stimulation therapies, before even the patient start taking oral opioids, then the clinical results are much better. The concepts are changing over time. This is a really interesting article about the history of the synapse from Plato to Sherrington. This is based on works of many scientists, Empedocles, Democritus, Pythagoras, Plato, Aristotle, Galen, Erasistratus, and many more. So you see, it's not only the therapies, it's also the concepts that are changing over time. In the spinal cord stimulation field, everything started with this publication, 1965, in Science, the famous gate control theory, activation of alpha-beta fibers inhibits the transmission of pain to the brain. 2 years later, 1967, we had the first clinical application of spinal cord stimulation in the United States in a patient with lung cancer. Back then, it was a completely experimental therapy, but the daughter of the patient was a nurse in the anesthesiology department and convinced her father to undergo this surgery. The colleagues implanted a lead. The patient was satisfied, had a pain relief, but unfortunately, he died 6 days later because of endocarditis. What are we stimulating in spinal cord stimulation? We stimulate the dorsal columns, the dorsal horns, or maybe both of them. The goal here is to implant 1 or 2 leads in the epidural space, to do a trial, and if the patient is satisfied, to connect the leads to a neurostimulator. How it works, we don't know 100%. We do know that we have segmental spinal effects, but we also have descending inhibitory pathways. The history of spinal cord stimulation, 1974, here in Freiburg, in Germany, the first spinal cord stimulation meeting. These were very famous colleagues back then, and all the devices you can see here are radiofrequency receivers. They were devices that were implanted under the skin. There was no battery there, and each time the patient wanted to stimulate, he had to have this antenna, the circular thing, over the radiofrequency receiver. These were the very first steps. And back then, the colleagues started with leads with only 1 contact, then we had 2 contacts, 4 contacts. Now we have percutaneous leads, we have surgical leads, we have up to 32 contacts. And these are images you can see in the operating room using a C-arm. You can implant only 1 lead with 8 contacts. You can implant 2 leads with 8 contacts. You can implant 1 or 2 leads with 16 contacts. There's only 1 lead in the market with so many leads as a percutaneous lead. And this exactly the lead is something that we implanted for the first time in Europe in 2018 in my hospital. We have neurostimulators, and then we have 2 options. We have rechargeable ones. It is the right one on this picture, and non-rechargeable ones, the left one. You see the non-rechargeable are a little bit bigger, and we have to replace them every 1 to 3 years. The rechargeable ones have a life expectancy of 10 to 12 years. Always, for all therapies, there are some indications, there are some contraindications, but unfortunately, very frequently, there are also some gray zones. These are some pictures taken at 6 o'clock in the morning. This is my home, the University Hospital of Cologne. You see the traffic lights, they are green, they are orange, they are red. It's exactly the same with spinal cord stimulation therapy. In each country, there are some guidelines. In Germany, we have these strict guidelines with inclusion criteria, pain, but it's not sufficiently treated with drugs or Other modalities, exclusion criteria, which are even more important, coagulopathies, mental disturbances, addiction problems, secondary gains, patients who are unable to use the spinal cord stimulation system, advanced malignant tumor, and infections in the area of implantation. The majority of patients who are reaching out to us are patients with persistent spinal pain syndrome. Why? Because we know that the failure rate of the lumbar spine surgery lies somewhere between 10 and 46%. And we also know that each time we offer one more spinal surgery, the patients are less and less satisfied. But spinal cord stimulation is a very good option, not only for patients with back or neck pain. One other indication, a very good indication, is angina pectoris, intractable angina pectoris. Here we can place a lead at C7 or T1, or patients with peripheral vascular disease, if it's possible, stages 2B or 3. In some patients also in stages 4. Here we implant a lead with a tip at T10. It's always a good idea to cover both lengths. If you're interested in the topic, this is a review article coming from my department, published in the British Journal of Neurosurgery, about spinal cord stimulation and peripheral vascular disease. If you don't like reading, this is a YouTube video about the same topic. You can watch it on YouTube. We can combine spinal cord stimulation with other therapies. We can combine spinal cord stimulation with intrathecal pumps. We can combine spinal cord stimulation with subcutaneous leads. This is a good example. A patient had an accident. In the beginning, the colleagues implanted 2 subcutaneous leads. You can see the scar. Parallel to the scar, 2 subcutaneous leads. The patient was satisfied, but some years later, he came back with more pain. We had to implant a spinal cord stimulation lead, an epidural lead, and now the patient has a combination of 2 therapies and he's really satisfied. We have many waveforms. The gold standard spinal cord stimulation is the tonic stimulation. The patient has a tingling cessation, but nowadays we have many waveforms. And why is this important? This is Alma, born in Britain. Some say she is the new Mozart. She loves improvisations.
And then I would improvise a piece based on the notes.
All right, hand me that then. Close my eyes.
Close your eyes. Si bemol. Mi. Si bemol. La.
And as Alma says, music is the melodies. It does not have to be very complex and serious, but the people should like to listen to it. It's the same thing with spinal cord stimulation, and the waveforms we are applying, they should be pleasant for our brain. I'm coming from Greece. I have to combine everything with philosophy. So if you have a look at the definition of music, music is defined as the science or art of ordering tones or sounds in succession, in combination, and in temporal relationships to produce a composition having unity and continuity. This is exactly what we are doing with all different types of spinal cord stimulation. And this is important. Rauch showed at a congress at NANS 2015 that different types of stimulation, here the standard high frequency, and subperception stimulations without tingling with 1 kilohertz frequency are stimulating different areas in the brain, implying that there are different mechanisms of action. There is also the discussion if we actually need a trial before implanting the permanent neurostimulator, or we should do an all-in-one procedure, leads plus neurostimulator. And there are corresponding articles which show that we do have savings without doing a screening trial, but we have to have a success trial rate of 55% if we're implanting non-rechargeable systems, which are not so expensive, and a success rate of 85% if we're implanting rechargeable systems. Of course, there are other factors, not only the financial ones. If we don't do a trial, we have less infections, less punctures, less productivity losses. And then comes also the question, are trials predictive of long-term outcomes? A very interesting article published in Pain from Samuel Dabe and his team, showing that a screening trial in spinal cord stimulation has a sensitivity of 100%, but a specificity of only 8%. And the authors conclude that although a spinal cord stimulation screening trial may have some diagnostic utility, it provides no patient outcome benefits. So do we really need trials? If you are interested in that topic, you can read this editorial in the International Journal of Neurosurgery. Comes from me, and it is for free. I hope it's not boring for you. Let's move on to the second point, how we go to the new spinal cord stimulation systems that we have. As I mentioned, the gold standard spinal cord stimulation is the tonic stimulation. We also have other waveforms. The question is if a monotonous repetition of electrical impulses, it could be tonic stimulation or something different, if this is boring for the brain. Let's say that this turbine here is the brain. If the brain is doing or hearing the same thing all the time, it might be that at some point the brain does not respond to the stimulation. Then we have this habituation or loss of efficacy effect. This is why maybe it's a good idea to have different types of stimulation, or even a better idea to combine different types of stimulation at the same time. So I think you got the idea. We have the tonic stimulation. We also have a high-frequency stimulation. This is an animation coming from a specific
Chronic pain
company
can arise from
that knows
numerous
very well
conditions
the
and have
difference
many
between
negative
tonic
impacts on a
stimulation
person's
and
life.
high-frequency stimulation.
Hyperactivity of the wide dynamic range neurons, or WDRs, which project pain signals to the brain, is believed to contribute to chronic pain. The goal of spinal cord stimulation is to suppress this neural hyperactivity and therefore reduce pain signaling to the brain. Treatment for chronic back and leg pain includes the use of traditional spinal cord stimulation, SCS, in which dorsal column fibers are targeted to reduce pain. Traditional SCS delivers strong low-frequency pulses to activate these dorsal column fibers, generating paresthesia, a tingling sensation that must cover the patient's painful area. Obtaining and maintaining paresthesia coverage for back pain can be difficult, leading to poor long-term outcomes. HF10 therapy has been uniquely developed as a more efficacious and paresthesia-free therapy. Rather than stimulating the dorsal columns, it is believed to work by more directly targeting the dorsal horn, using consistent lead placement proximal to the painful spinal segments and a high frequency of 10 kHz. The result is greater neural inhibition and thus greater efficacy.
We also have the burst stimulation. Here we have packets of high-frequency pulses. This is also a sub-perception stimulation. The patient does not feel any tingling. And this is important because this type of stimulation can act not only at the lateral pathway, which is responsible for the perception of pain, but also on the medial pathway, which is responsible for the affective components of pain, the emotional reaction to pain, for example, or the attention we're paying to pain. We also have a real combination therapy, and combination therapy means we can have two waveforms for the same pain area, or we can have a waveform A for back pain, for example, and waveform B for leg pain, or we can use different waveforms sequentially with the hope that over the next years, we're not going to have any loss of efficacy. Once again, if you're interested in the topic, you could read this editorial in the Internet Journal of Neurosurgery for free. And this is 2018, the first neurostimulator implanted in Europe with the in my hospital with the ability to provide all these waveforms as a combination form. And 2 years later, the first IPG, which could be also MRI compatible. Why this is important? Because we have to offer our patients a system that can provide different types of stimulation, but at the same time should be MRI compatible. We also have another option, the pairing of waveforms, meaning you can have a stimulation with high frequency and then change to tonic stimulation, then back to high frequency, or you can have high frequency, change to bursts, and then back to high frequency. This is not a combination therapy, this is a pairing of waveforms. A new technology is the closed loop stimulation. The first article published 2017 in neuromodulation. Here you have 1 or 2 leads epidurally. The lead can capture any cap, an evoked compound action potential, can compare the amplitude with a set point, can calculate a new stimulation current and generate new stimuli, and the whole loop goes on and on. The classical system, the open loop stimulation systems, have a disadvantage. The stimulation, this black line, does not always stay within this therapeutic window, meaning that if the patient is standing or sitting or is supine, this plays a role. And sometimes we have an overstimulation, sometimes we have a hypostimulation. With the closed loop stimulation systems, we have a stimulation which is almost always within the therapeutic window, meaning that if the patient is standing or sitting or if coughing, this does not play a role for the stimulation. An animation showing the concept, we stimulate. Because of the stimulation, an ECAP is generated. The lead can measure the ECAP and change the stimulation. If you read a neurophysiology book, you see that this ECAP has 2 positive waves, 1 negative, 1. But in the real world, this is how it looks like in the operating room. This is an ECAP. There are many studies based now on this closed loop stimulation. Avalon study coming from Australia, EVOKE study coming from the United States. We also have 24 months results. I have made a table for you just to have an overview of these studies. For me, this pain relief, which is really impressive, is not that important. For me, what's really important is that almost 70% of patients after 2 years with this therapy eliminated or reduced the opioid intake. Another algorithm is the DTM algorithm, differential target multiplexed. Here we can stimulate at the same time neurons and glial cells. Why is this important? Because glial cells are involved in many processes, among others, neuroinflammation, amplification, modulation, and distortion of afferent sensory signals. And we know that these cells outnumber neurons in the spinal cord. The ratio is 12:1, so they must be pretty important. There are many studies in animals. This comes from Vallejo and his team, showing that this algorithm reduces mechanical and thermal hypersensitivity. A second article on animals, experimental work from Vallejo and his team as well, showed that chronic pain and subsequent spinal cord stimulation treatments can modulate microglial activation transcriptomes. Of course, we have studies with humans as well, showing that leg pain and back pain with this algorithm can be much less after 1 year. This is the placement of the leads for this stimulation. We should cover T8 to T10. The placement of the lead here is really important for this algorithm. And here on the picture, you can see the neurostimulator which could provide this new type of stimulation. Actually, here we have 4 programs that are running, 1 basic program with 50 Hertz and 3 prime programs with 300 Hertz. The newest waveform that we have is called fast-acting subperception therapy, 90 Hertz, 220 microseconds pulse width is subperception. The patient is not feeling anything, does not have a tingling sensation, and the pain relief is coming within seconds or minutes. and an animation explaining
Professor Warren Grill of Duke
action
University
with
recently
surround
explored the
inhibition.
impact of surround inhibition on SCS. Here's how it works. In the gate control theory, small sensory fibers send pain signals to the wide dynamic range or WDR neurons, which are then transmitted to the brain. Conventional SCS activates larger sensory A-beta fibers from the center area of pain. These fibers activate inhibitory neurons, which limit WDR firing and immediately reduce pain, despite also causing some WDR excitation. Conventional SCS also activates some sensory A-beta fibers from the region surrounding the painful center. These fibers only engage inhibition without exciting the center WDR neuron, providing additional immediate pain relief. Using the proprietary Illumina 3D algorithm, we're able to more precisely target the optimal location, covering more of the surround fibers. Combining Illumina 3D targeting with the proper neural dose and a unique active recharge waveform, FAST is designed to preferentially engage these surround fibers while minimizing
We have
center
a
excitation.
new mechanism of action. This is the important thing. Here we have clinical results, 6 months follow-up. We have a difference of 86% in pain relief, pretty good. And we have also 12-month results, which are stable. What's really interesting here is that the pain relief is coming within the first 11 minutes after the activation of the system, and that the energy usage is much less. If we compare this waveform with stimulation of 10 kilohertz, we see that we need 95% less energy. We have clinical data for spinal cord stimulation. We have basic science, case studies, retrospective studies, prospective studies, randomized control studies. Every company has such studies. From a specific company are coming these studies, real world studies or level 1 RCTs that are showing the effectiveness of this therapy. Interesting studies, at least for me, are the following two ones. You see here is the PROCO study. The colleagues try to show if there's a difference if we stimulate with 10 kilohertz, 7 kilohertz, 4 kilohertz, or 1 kilohertz. And they found that actually 1 kilohertz is pretty good with less energy demand. And one step further, the HALO study, the colleagues evaluated another frequencies with 1000 hertz, 600 hertz, 400 hertz, 200 hertz, 100 hertz, 50 hertz, and 10 hertz. And they saw that actually also with a lower frequency, the pain relief is pretty good, with the best results with a frequency of 200 hertz. I sincerely hope you are still with me. This is a study coming from my department, a retrospective study with 1.2 kilohertz stimulation and combination waveforms by patients who already had a system, but they were not satisfied after some months or years with complete loss of effect. The patients had the possibility to remove the system or to try this combination therapy. During the trial, we had an 80% responder rate. So we had 29 responders and 8 non-responders. And from out of these 29 responders, after 1 year, you see a difference of 43% in pain relief. So the patients were satisfied. Hopefully you are really still with me, and let's go to the exciting things. Why we have a new era? We have a new era because we have different waveforms and we have different mechanisms of action. In combination could lead to a profound pain relief. We can act at the dorsal horns, we can act at the dorsal columns, or at both sides at the same time. If you have a look at the studies from different companies, you see that the Oswest's disability index, the disability of the patients, is becoming less using spinal cord stimulation systems. And the patient satisfaction, if you have a look at the studies from different companies as well, is really good. Previously, we had different algorithms for spinal cord stimulation in patients with back pain. It was important to know if we had only leg pain or back pain, if it is local back pain or diffuse back pain. And back then we used many subcutaneous leads, this peripheral nerve stimulation therapy. Nowadays, with the new waveforms, we can treat the majority of patients using only spinal cord stimulation therapy. And the future of spinal cord stimulation, new systems. This is something I found on the internet just got the FDA approval to start clinical studies in the United States with a frequency of 500 kilohertz, a very, very high frequency. Let's see how the clinical results would look like. Another interesting invention is this brain-computer interface via endovascular surgery, like a stent. It was intended to be treated in to treat patients with paralysis, so patients after stroke, trauma, or neuromuscular diseases, but I'm pretty sure that in the future we're going to use such devices to treat chronic pain as well. It's only a matter of time. In the future, we're going to need even more data. If you have some time, your readers, you can read this editorial about big data written by me. You know that all companies have applications or are gathering data in order to be able to understand the chronic pain, to provide new waveforms. We have the ability to use now the artificial intelligence, and all big medical device companies are working with artificial intelligence companies. Artificial intelligence can be used in many fields. For example, here in Germany, musicians used artificial intelligence in 2021 and completed the 10th Symphony of Beethoven. Beethoven died before being able to complete it, and the scientists did it. They completed it and they showed it to the public. So artificial intelligence can be used in many fields. Merged reality, we can play 2 real-time video streams into a collaborative, interactive environment. For example, I can be in the University Hospital of Cologne. My rep who is doing the program can be in Greece. He can see what I'm seeing, and he can show on my phone what I should do on the laptop. We have the option of remote programming. This is a good example. I'm in my office. I have a sales rep in the room of the patient, and we have a second sales rep in another country, and we can all work together to provide the best possible result to our patients. A more exotic indication for spinal cord stimulation is respiratory function. Respiratory function in patients with complete spinal cord injury. We can implant leads at 2 to 5 and reduce the time on mechanical ventilation. And doing so, we can reduce the related complications. If you're interested, you can read the article. I'm involved there as well. Even more interesting, the new waveforms, FAST, for example, can be used for mixed pain syndromes. For patients who have a combination of neuropathic pain, and this is the main indication for spinal cord stimulation, neuropathic pain, but also now we can treat partially some sort of nociceptive pain. This is only a small case series of 14 patients from my department published in many international congresses, showing that after 6 months, we have a big difference in the pain scores, but even more importantly, the disability index reduces and the quality of life increases. Pain relief is more important than waveforms. This is a photo coming from Ikaria, the small island in Greece, and there I took these 3 photos. You see some fire engines. 2 of them are not used. The third one in the middle is used in order to, just in case there are some fires. And you see this is not a new vehicle, but still does its job. It's the same thing with spinal cord stimulation. In many cases, the gold standard, the traditional tonic stimulation can be really good. We don't need anything more, but it's always nice to have other options if the pain is really severe. A very interesting article for the future, tonic stimulation and subarachnoid hemorrhage, an article of 2022 from Slavin and Vanim Reddy. The colleagues used a tonic stimulation with 60 Hz for 2 weeks after the rupture of an aneurysm. And they tried to see if this could help the vasoconstriction. But this animation shows very well the relationship between chronic pain physicians. Tom here is the pain physician, and Jerry is chronic pain. We are sure we can help many patients, but in the end, we cannot. Something I found on Instagram, it's about emails, but we can modify it for chronic pain patients. We have a patient with chronic pain. We think that chronic pain is treated, but the chronic pain patient is coming back to our patient department with pain because we have forgotten to treat the emotional and cognitive aspects of pain. Referral tools are always useful for general practitioners or neurologists. This is a good example. You can register, it's for free. You can give the clinical data of your patients, and the system will make a recommendation if the patient is a good candidate for a spinal cord stimulation therapy or not. The main concept is to keep evolving. As Benjamin Franklin wrote, either write something worth reading or do something worth writing. And spinal cord stimulation and the new waveforms is something really worth doing and offering our patients. Just don't forget, we need compassion. And as this American philosopher Eric Hoffer wrote, compassion is the antitoxin of the soul, not only for the patients, but also for ourselves, for the physicians. This is an article I'm also involved here, published here in Germany, about burnout in medical personnel, in surgery and anesthesia in the COVID time. So we have to take care of ourselves as well. We need collaboration and national collaboration. We need international collaborations. And this is why we're doing this today on Pain Talks, in order to raise awareness, to inform more colleagues about these options. We need collaboration. All these people you see here are sales reps or company reps. They are helping me with the programming of the patients, and they are the reason why our results are so good. I have to thank all these guys. If you're interested in the topic, please follow the social media accounts of Journal of Neuromodulation on Facebook, Twitter, and Instagram. Please follow the social media accounts of Pain Talks Education on LinkedIn, on Facebook, and on YouTube. If you're interested in neuromodulation, spinal cord stimulation, you could read these books, The Hard Book of Neuromodulation, I'm editor here, or my book, Recent Development Spinal Cord Stimulation. If you have any questions, I will be glad to answer them. You can always reach out to me using this email address. I will get back to you. Once again, Sadik, thank you very much for your kind invitation. Thanks for letting me raising awareness.
Thank you so much, Georgios. That was a great talk with a mixture of philosophy, mixture of science, mixture of great cartoon and analogy of Tom and Jerry. I really liked that. You made that very entertaining and all at the same time very educational. So thank you so much. I think if you have any questions, please do write in the chat box, and then we will kind of try and answer that. Georgios, the question I have is, you said we want patients to be kind of, assessed for the suitability of spinal cord stimulation. And you showed us a paper where they said, instead of going for a trial, you go ahead and just implant the lead and put it as like a permanent implant rather than but what's your take on it? Because you have been doing neuromodulation for a long period of time. Would you still go with the traditional trial followed by a permanent implant, or would you support the argument that it's quite expensive to go through the trial and then implant in the patient, go ahead and just implant? And so what's your take on it? That's what I want to know.
This is a very good question, and the answer should be complicated as well, because it depends on the setting where somebody is working.
Okay.
Scientifically speaking, I think it's better to do a trial. Although all these publications, and surprisingly, all of them are coming from the United Kingdom, all
Right.
these publications are showing that actually we don't need to do any trials because the results are really good without trialing. So
Okay.
we can
Go-
save costs. You could do probably that based on these publications if you are really, really selective when you are setting the indication for this therapy.
Okay.
So if you have a typical spinal cord stimulation patient, then you could do it.
Okay.
On the other hand, it depends if you're working in a private setting, in a private hospital, or if you're working in a university hospital. In my department, I have the luxury to have time, meaning that I can invest 30, 40 minutes time in the operating room to get the optimal coverage of the pain by changing the position of the lead intraoperatively till I'm satisfied. This helps me in the future because all the new waveforms, or most of them, don't really need a very good coverage of the pain area. There are some others, like tonic stimulation or the fast algorithm, which really need an 100% coverage of the pain area, not 90%, 100%.
Right.
So my approach is to take the time intraoperatively, to do a very good trial intraoperatively, test after for 1 or 2 weeks maximum, and when the patient is satisfied, only then implant the neurostimulator. There are different approaches. It depends on the country, it depends on the specialty, it depends on the hospital you're working in.
Right, I got you. So I think it all depends on the logistics and how the kind of system works for you in your country. So okay, that's a very good answer, because I think majority.
I must do also a comment. The whole history started in the UK because of COVID, and the colleagues, mainly anesthesiologists, are in the UK who are providing this therapy, did not have any slots in the operating room for doing such cases.
So they just
So
decided.
they tried to find a solution, and the solution was to do a pretty quick on-table trialing. And if they saw that the pain coverage were more or less okay, they implanted the neurostimulator as well. This is how the whole thing started.
So it was a COVID that was responsible for pushing the trial into one-stop kind of permanent implantation. Right. Okay.
Exactly. It's a
Okay.
fast track.
Fast track, and I agree, because obviously I worked in the NHS, and I think you don't want the patient to wait for a long time for the permanent implant. And you're going to spend months, because you will do a trial, and then once the trial is successful, then you will put them back on the list for the permanent implant. And I think a lot of people are now doing that staged approach, because when they're doing a trial, they are tunneling, and they are basically not implanting the IPG. They are basically leaving the IPG kind of for a later stage, and they're just converting them from stage 1 to stage 2, which is basically much.
Don't forget, in the United States, it's completely different.
Yeah.
The colleagues there are doing a trial. Let's say colleague A is doing a trial,
Yeah.
and then he removes the lead.
Right.
And if the patient is satisfied, goes to a colleague B, who is implanting the permanent system, permanent lead plus neurostimulator. So it's a completely different system.
Right. I think I think it's based on the country you're working, right? Okay, we have one more question. Which SCS system would you say is best for cluster headaches?
Cluster headaches are not an indication for spinal cord stimulation therapy. For cluster headache, one could try ONS, occipital nerve stimulation. You could do a pulse radio frequency there if you want. You can implant subcutaneous leads in this area if you want. These are some options. If you do all these things, and if the patient doesn't have any pain relief, experimentally, you could implant a cervical lead with the tip at C2 and try indirectly to stimulate the trigeminal nucleus in the brainstem, because we know there are connections between these targets, and sometimes it works. But I would not say that cluster headaches is an indication for spinal cord stimulation.
Usually, I think they want to follow the medical management first with the high flow oxygen, 100% oxygen, and then people undergo pterygopalatine fossa blocks, and then followed by that occipital nerve block, and then occipital nerve field stimulation, followed by the permanent implantation of the leads. I think that's the protocol. Majority of people would agree. I think, as you said, it's experimental to put in a cervical spinal cord lead to treat the cluster headaches, because it's not something that's well known, and it's still experimental. I don't think I've come across any RCT on that. I'm not sure whether you come across any RCT, Georgios.
You will not.
No, you will not, because it's
in the next many years you will not.
It is an experimental indication. So okay, great. I think we're pretty much covered, Georgios, with regards to we do have people from Paraguay. Okay, great. Greetings. So guys, I think what I would do is just ask your opinion on if you guys would be interested in the examination webinars. So if you're planning to do the exams, then we are planning to put up some webinars at the end of September, beginning of October. But if you want to keep yourself updated, then you just go onto the Pain Talks Facebook page. You will be able to find the announcements for the webinar. And we do have Dr. Peter Statz from World Institute of Pain. He's the chairman of World Institute of Pain, who will be doing a talk on vagal nerve stimulation, because we are continuing with the theme of nerve stimulators, neuromodulation, and other webinars in the month of September, because September is a pain awareness month. So we will keep you posted with that date and the time for his webinar on vagal nerve stimulation. And thank you so much, Georgios, once again for joining us and giving us your precious time and enlightening us with a good amount of concepts on the future and the history of spinal cord stimulation. So thanks very much. And as I said, the webinar recordings will be available on the Pain Talks YouTube channel. So if you guys want to access that, then do feel free to kind of join the YouTube channel of Pain Talks. Thanks very much, everyone, and we will see you again in the future webinars. Thank you so much. Thanks a lot.